So hello everyone. We're just going to wait a couple more minutes in order for letting people to join us before we start. So let's start. So good afternoon, everyone, ladies and gentlemen. It is with great pleasure that on behalf of the Portuguese Association of Hospital Managers, I welcome you all here to our third webinar of this webinar cycle, which is part of the fourth edition of the program Mais Valor em Saúde, Vidas que Valem. This program was born out of the growing mobilization of healthcare professionals, managers, and policymakers around the need to transform our healthcare system by adopting the value-based healthcare model. As you know, the value-based care model seeks to optimize care delivery, focus on outcomes that truly matter to patients, meaning value creation and the efficient use of available resources, of course. The success of this program has been made possible thanks to a strategic partnership between APA and the biopharmaceutical company Gilead Sciences, the consulting firm Exigo, and joining us this year, the consulting firm Vision for Health, here represented by Felipe Costa. Thank you, Felipe, our co-host for this webinar cycle, and with technological support from Meu Empresas. To our partners, we extend our sincere thanks for their commitment and dedication to promoting a culture of value in healthcare. Since its inception, Mais Valor em Saúde has focused on three fundamental pillars. So first pillar, capacity building. Through training incubators, we have equipped healthcare professionals with the principles and methodologies of value-based healthcare, enabling them to identify meaningful health outcomes and understanding optimized care delivery models. Second pillar, implementation. Through Mais Valor em Saúde grants, we hand out 4 grants in each edition, 50,000 euros each. We have supported SNS teams in the practical implementation of these methodologies, working alongside specialized consultants from our consultancy firms, partners. The third pillar, continuous improvement, because our ultimate goal is the continuous improvement of health indicators, outcomes, and patient satisfaction, promoting efficient patient-centered care. With this new cycle of online webinars that we launched this week, we are continuing the capacity building pillar now in a new format, which is more accessible, more flexible, allowing us to reach more professionals across the country, keeping alive the sharing network we have been building. So this week, on Monday, we welcomed Daniel Haber from Unimed Franca, Brazil. Yesterday, we were joined by Sally Lewis with the example of NHS Wales. And today we have Catherine McLean with a specific profile of a surgical hospital on orthopedics. Thank you, Catherine, for joining us this afternoon. As usually, we count on you and your active participations, your questions, your comments, your contributions, because only by doing so can you continue to grow together and drive the change we want to see in our healthcare system. I would like to end by thanking the local health units and their teams who throughout the various editions of the program have welcomed, tested, and scaled up the best practices identified. On behalf of APA, thank you all for your presence, your engagements, and your willingness to be here with us today. And I wish you all an excellent webinar. Philippe, now the floor is yours. Thank you.
Thank you, Raquel. And first of all, let me make a thank for everyone that is at home to really continue to see us and to be with us on this journey. But the main thanks now comes to Catherine McLean. I don't have enough words to describe the relevance of the person that we have today, you know, because from the first day that we met, we could see how is really value-based healthcare being implemented in the real practical field. Because we see a lot of people talking, but very few people about doing it. And Catherine has been a huge traction on being chief value medical officer, and also in a big hospital like Hospital Special Surgery. And not only there, but I'm sure that she will bring her knowledge to the world much more deeply, because we need more people like this, that people have put their hands really on the real practical field. And let me say that I know all the world about value-based healthcare, and Catherine McLean is, for me, in one of the biggest persons that have implemented value-based healthcare and has a huge deep knowledge when it comes to prompts and implementation, and her experience is huge in everything that has been done. And besides that, not only doing it, but also to be among who's publishing, you know. And it's important now, her relationship even with the New England General Medical Catalyst, which is a huge benefit for bringing all the evidence into this world, not only academic, but to publishing. Catherine, thank you very much for being us today. For us, it's a huge privilege to have your experience and your knowledge. And I'm sure that all the questions that will be raised, it's going to be a privilege to hear about your experience. Thank you.
Thanks for those kind words, Felipe. I just want to say that I had the privilege to visit Portugal, Lisbon, a few years ago, and to visit a few of your hospitals. And I was very impressed with what I saw in terms of the care delivery system, and additionally, the commitment toward advancing value-based care. I think that the setup in Portugal it's different than the United States in a good way. Sometimes when I'm speaking in other countries, I hear people talking about how they want to adopt certain structures that we have in place in the US. And I just want to say, you know, time out, stop, don't do that, because that's not going to get you where you want to be in value-based care. So anyways, let me pull up my slides. And get to the first one. Go into presentation mode. All right. So as Felipe mentioned, I am Catherine McLean. I am a physician. I would call myself an applied health services researcher. I've served in the role as a hospital administrator for the last about 9 years. I was, until the end of this past year, the chief value medical officer at the Hospital for Special Surgery in New York City, and I'll be going through our experience there. And I've kind of stepped away from that role to try my hand at, some consulting and some other, I think, kind of more interesting opportunities that are that have made themselves available to me. So anyways, let me go through this, and I'll be happy to answer all your questions. So just what is HSS? HSS is the Hospital for Special Surgery. It's an orthopedic hospital or care delivery system with the headquarters in the Upper East Side of New York City. It was started in 1863 as the Society for the Prevention of Crippling for Children, and it wasn't even a surgical hospital. It started out as a hospital to treat children with spinal deformities, but has grown a lot. Now there are over 20 locations across what we call the tri-state area: New York, New Jersey, and Connecticut. One hospital in Upper East Side New York, but many clinics and ambulatory surgical centers have been put together. Lots of laboratories. HSS is an academic institution. I would say it's a very applied academic institution. But there's, research, a huge volume of orthopedic surgery. So over 35,000 procedures a year, and HSS alone performs over 1% of all joint replacements in the United States. So it's a really big place in terms of orthopedics. This is kind of, how it lays out. The base of the pyramid is many PAs, physician assistants, nurse practitioners, nurses, physical therapists. And then at the top of the pyramid, we have about 130 surgeons, all orthopedic surgeons across different service lines in orthopedics. So very specialized within orthopedics. So we have surgeons who only do hip or knee replacements. We have surgeons who only do hand and upper extremity, who, only do limb lengthening. So it's very specialized. And then there's every sort of medical specialty wraparound that to support not just the surgery, but to support the delivery of musculoskeletal care, whether the patient needs surgery or not. And I think that's as a really important component of value-based care, is making sure patients get what they need and nothing more. So there's no lower value care than a procedure that was unnecessary, which is costly and puts the patient at risk for complications. So a big part of HSS's value proposition is having this whole wraparound and not doing procedures that are not indicated, but being able to treat patients in a non-surgical way. So for example, if a patient were to come to a spine surgeon or a spine surgeon at HSS, and the surgeon determined that, no, you don't need surgery, go see somebody else. And if that patient isn't managed, they're going to end up, down the street in some other surgeon's office and get an unnecessary spine surgery. So it's not enough for a surgeon to simply say, no, you don't need the surgery. It's like, no, you don't need the surgery, and I'm going to plug you into a system that's going to take care of your back pain. Nobody wants to have back surgery. So if a patient shows up in a surgeon's office, they're having a lot of pain. We need to take care of it. So kind of some background HSS and some metrics. It's a very high quality place. So as you know, value is quality over cost. And here we have the components of that equation. So many external entities evaluate quality in the United States, and here are some of those entities. So HSS has been a 5 out of 5 star hospital, is rated by the Centers for Medicare and Medicaid Services since they started doing that rating in 2016, has achieved #1 with US News and World Report 15 years running, #3 in rheumatology. Newsweek rates HSS as #1 in the world. And then the Net Promoter Score, exceeds that of consumer favorites such as Starbucks. Starbucks might not be a favorite in Portugal, but it is a favorite in the US. Starbucks, Netflix, or Disney. Everybody loves Disney. And then on the cost side, there are a number of different objective measures that demonstrate that HSS is a cost-effective organization. Medicare, the Centers for Medicare and Medicaid Services in the United States has a metric called Medicare spending per beneficiary. And basically what that is for any hospitalized patient in the United States, Medicare hospitalized patient in the United States, Medicare looks at the cost of the hospitalization and the cost of the following 30 days, right? So that's an episode cost. And then Medicare looks to see, they do some adjustment for geographic area and payment. Medicare payment is standard across the US, although it's adjusted for the wage index in different geographic areas. So anyway, so Medicare, you know, comes up with a number in the percentile. And so HSS is in the most favorable 16th percentile in the United States in terms of being efficient. And I think that's a particularly interesting number for a surgical hospital. Every single patient that gets admitted to HSS is going to have a procedure. So they're already kind of an expensive group of patients. Yet, you know, despite even though they're all having surgery, HSS comes in the most favorable 16th percentile. We have replicated those types of analyses using commercial claims and have demonstrated that same sort of Medicare's, you know, spending per beneficiary for commercial patients, which is favorable in the market where HSS is in the tri-state area. And episode costs for TKA and THA and spine surgery are the lowest in New York City. So we've got the quality on the left-hand side of the slide and the cost on the right-hand side. So I think we can make a good argument that HSS is a high value place. So how do you produce that high value care? I'm going to take you through some conceptual pieces, kind of mirroring, you know, the idea of your society, you know, looking at the concept and the measures, the implementation, continuous improvement, and capacity building. And I won't talk about that now, but as HSS expands, you know, it has to have the capacity to duplicate this over many locations. So I think the first thing is to define your organizational principles for high value care. And I think the thing that's really important about this is like everybody in the organization has to be in on it. So the clinicians have to buy in on it. You know, when I showed up at HSS 9 years ago, I had come there directly from a health plan. You know, before that, I had been a practicing, you know, clinician in an academic health center. But I think they thought, who is this woman? And she's just going to try to value just means cheap care. And, you know, we're not in on that. That just means insurance company cost cutting. And they, you know, weren't real enthusiastic about that. But, you know, there was a lot of education that had to go on to understand what value was, and then pulling people in. So these aren't my principles. These are the principles we developed at HSS as a group. And so the number one principle is patient first. And so at HSS, the principle is to deliver the highest quality care in the most cost-effective way. So the patient drives it all. The quality drives it all. It's not to, you know, cut costs and keep the quality at an okay level. It's to always drive to the highest quality, to maintain that number one, and while doing it, do it in a cost-efficient way. Now, delivering high-quality care has there's costs involved in delivering that care, but you know, if you're delivering high-quality care, you're going to have less complications, less readmissions, and you know, it ends up being cost-effective. So, number one, patient first. Improve health consistent with patient preferences. PROMs, you know, fit into this. Avoid harm, both physical and financial. Practice evidence-based care. So base your decisions on the best available evidence. Utilize diagnostic and therapeutic services with evidence of efficacy. There's lots of stuff out there that people want to try out, and the evidence just doesn't exist, right? Or it's shaky, right? And you know, you really need to be doing things that work, and don't do diagnostic or therapeutic services with evidence of little or no effect. So if it's not going to help, or it's going to barely help, you really have to have a conversation with the patient about that, and you're probably not going to do it. Avoid unnecessary care. It's costly and potentially dangerous. As I mentioned, the lowest value care out there is care that's unnecessary. It's expensive, and you're putting your patients at risk for complications. Standardize efficient care pathways. Utilize the least expensive therapies for a desired outcome. So for many inputs in the health system, there are options So if you're using implants, you're using a screw, use the one that costs the least amount of money, unless there's some reason that there's some screw that's better than another one, but that's generally not the case with the screws. There are, there are often alternatives. Use the least expensive option. And then lastly, manage the entire episode of care and address the condition, and as you said, patient first. So this isn't about how much does it cost to do a knee replacement surgery, the day the patient comes to the hospital. It's how much does it cost to manage that whole episode of care, and, treat that patient, for their lifetime. Or if it's someone who has back pain, it's managing that back pain and they maybe don't even need to have surgery. So those are the principles. So I think that's the number one thing you need to sort out within your organization is, what are your principles? And, I can think of different iterations of this that I'll get at high value care, but it has to resonate with your organization, with your clinicians, with your administrative staff, with everybody. All right. And then develop a care episode framework. This is work that we did as part of the CGR program, which I'll go into in a minute. This is published. But we really developed a pathways program. This was initially developed for hip and knee replacement, but this is, is applicable really to any procedure, and has been adopted broadly. And so, the components are, one, to develop a pathways program. So underneath every one of these little boxes, there are all kinds of pathways that live in the electronic medical record. There's order sets, and it's pretty standardized. And then, underlying this is, analytics, monitoring, and coordination across the whole care episode. So you really have to analyze whether what you're doing is working. So is it working in terms, and I'll show you some of the analyses, but is it working in terms of lots of different metrics that are going to matter to your hospital? Is it working in terms of throughput? Is it working in terms of complications? Is it working in terms of cost? Is it, working in terms of, relevant patient outcomes? So you got to be looking at all of these things. So, in this pathway, pre-admission, screening and triage, and that's a really important component. Does this patient need does this patient need surgery or not? And if not, then they're going to go, see somebody who can treat them non-surgically. If they do, then, off to the surgeon they go. Surgeon makes a determination, and then there's a whole health optimization program. So if a patient has diabetes, their blood sugar needs to be under control. If they have hypertension, their blood pressure needs to be under control, and on and on. So looking at, their risk for serious complications, and the patients are optimized. Weight management is a big component of this. HSS now has a lifestyle management program, which is one way for patients to work on losing weight before surgery. Some of the patients with osteoarthritis who are looking to have a knee replacement, if they lose enough weight, sometimes they don't need to have the surgery. That's not most patients, but it does happen. So that health optimization is really important. Then there's a surgical readiness visit. And we had found that many of our patients were being discharged to a nursing home. They didn't need to go to a nursing home. There was, I think, a little bit of trepidation if we stopped sending patients to nursing homes. Would they do okay at home? And it took a lot of education with the surgeons and a lot of analyses, as we were going on. We had to demonstrate that, no, this is not resulting in bad outcomes for our patients. And in fact, the readmission rate went down. After you have a knee, when you walk in for a knee replacement, being discharged to a nursing home is not a good thing. You're going to be laying in a bed, you're exposed to, other patients who may be ill. You have a higher risk for a blood clot if you're laying in bed all day. Anyways, so we put together this whole program where physical therapists do a big part of that preoperative assessment. That's typically something that's done by social workers, at least in the US. But we put the physical therapists in that role because we felt that they had the knowledge, they could really understand what a patient was going to be able to do after the surgery or not. Then before surgery, there's a pre-admission phone call, just to make sure the patient, everything's okay with the patient. And if things aren't okay, you know, we will stop the surgery on admission. There's preoperative care. And if a patient shows up and, you know, their numbers are out of whack, you know, they will not have surgery that day. So, you know, and that's really disruptive. I realize I'm talking to a group of hospital administrators, very disruptive to have a patient scheduled for surgery and then have to cancel the surgery. You've got an open OR. It's not good. So that's why this pre-admission stuff is so important, because you want to make sure when the patient shows up on the day of surgery, you know, one, that the surgery is going to happen, and two, that their health is optimized for good outcomes. Surgery happens, then post-operative care, you know, in the hospital, then on discharge. So is the patient going to go to a skilled nursing facility or an acute inpatient rehab facility? As I'll go into some detail on this, we developed a program called HSS at Home, which is telephonic physical therapy in the post-acute space. So during those 6 weeks after discharge, there's this there's HSS at Home. You know, it's telephonic PT. Now, this isn't like major PT. This is, you know, can you bend your knee? You know, can you stand up? Can you take some steps? This isn't, you know, big stuff, but it's really important stuff. Then follow-up. There is a program where patients are monitored after discharge to make sure that they're okay. And if they're not, to get them into the hospital rather than them going to an ER or having a readmission. So that's basically the program that we put together. And as I mentioned, it's really important to track and evaluate what you're doing. So, you know, what quality measures matter. So we had a program, Measures That Matter. We talked to all the service lines to determine what quality measures matter to you. We talked to patients, what measures matter to them. We want to look at utilization of services. So what services are you using? How frequently are you using? What is the intensity of the service? So if someone is having physical therapy, you know, after surgery, how many patients are having physical therapy? It's probably most. What does the intensity need to be? We found that when patients were using the visiting nurse service, that they really were getting too much. And in fact, sometimes they'd show up for their follow-up visit and their knee would be warm and swollen. It's because they're getting too much physical therapy. So it has to be right. How effective are your services? How efficiently can you deliver them? I'll go back to the HSS at home example. It was way more efficient for us to deliver that post-operative physical therapy via video than it was to have a nurse going into the home. And then the cost of care, it's the absolute cost, the relative costs, and the ROI. And these are just some graphics. I won't go into much detail. The one on the top left is looking at the utilization of post-acute care, where patients were going. At the bottom left, this was really useful. It was really looking at by area where the patients lived, what kind of services they were getting. And so there's different availability in different areas and so on. All right, so let me go through an example of a program in the US. This program has sunset. It's being replaced this year with another program called TEAM, but this was the Comprehensive Care for a Joint Replacement Program. It is a retrospective model. So it's a Medicare fee-for-service model. And basically the way it works is that, you know, for Medicare beneficiaries in the US, there's a set payment schedule, and patients who are in this program, you know, they go to their doctor, they go to the hospital, a bill gets dropped, Medicare pays it, the patient pays their copay, and so on. And the way this bundle works is from the patient perspective, they just go through care their normal way. They go to see a doctor, the doctor bills, sends a bill to Medicare. They go to the hospital bills Medicare. They get discharged if they go to a nursing home, the nursing home bills Medicare, and so on. And that's kind of, that whole thing kind of goes on. But then there's a retrospective look back period, and this was a 90-day period. And so what CMS would do would be for each of the patients who were in this bundle, they would say, okay, this patient, was admitted on this day and then discharged on this day, and the total cost of care during that 90 days is, whatever number it is. And CMS would look in a region and say, okay, in this geographic region, over the last 3 years, patients who had a hip replacement or a knee replacement, the average 90-day cost was X. And then Medicare would take a discount off of that, 2%, and say, okay, the cost was, X, I'm going to take 2% off of that, and that's going to be the target price. So let's just say the target price was $25,000. And so patients would go through they'd go through their care. Medicare would go and look and see how much did the 90 days cost. And if the target was $25,000, if the cost of care was $30,000, then Medicare would say to the hospital, it's too expensive, you owe me $5,000. If the cost of care was less than $20,000 or $25,000, let's say it was $20,000, Medicare would say, good job, you came in under the target, here's $5,000 for you. So on and on with each and every patient that was in this program. I'll show you, we were very successful in that program. There were some other interesting elements of the program in that money you got back, the reconciliation money, there weren't many regulations around what you could do with it. And so that HSS at Home program, we funded that through, because Medicare at that time didn't pay for telephonic PT, we paid for it with that reconciliation money, but it ended up being cost saving in the end. So, our insights, I would say, with this program, and this is where the data and the analytics are really important. CMS made available the claims data for every beneficiary that was in this program. And so we got, as real as claims data can be, monthly, we would get the claims. Now, remember, claims, get adjudicated over a period of time. And typically, if you're out 90 days, you can be pretty confident that that's what the final cost is going to be. But at 30 days, the provider maybe hasn't dropped the bill yet. So anyways, we had these data and we looked very carefully at it. So some of the, insights just from looking at the data was that 40% of the costs of that 90-day episode occurred after discharge. These are surgical patients, and yet 40% of the cost was after discharge. In 2014, 13% of the patients discharged to a SNF had a, oops, sorry. Sorry about that. In 2014, 23% of the patients discharged to a SNF had a 23% of the patients were discharged, and there was a 26-day average length of stay. In 2019, 18% of the patients were discharged to a SNF and had a 12-day average length of stay. So it really decreased both the number of patients who went and the length of stay. I will just point out that Medicare will pay for 20 days. And so, the nursing homes were optimizing their revenue and keeping the patients in nursing home longer than they needed to be there. So we had a program where we tracked the patients very carefully. The health optimization program I'll go through in a minute, we identified 11 high-risk categories for which we screened and provided specific evaluations and treatment. And then the Pathways program, which I mentioned before. The thing on the health optimization, I just want to call out, and I'm not sure if you have a similar thing in Portugal, but for Medicare, whenever Medicare develops a quality measure, they do a really nice job. And I think this information, is probably relevant to the Portuguese population as well. They do a really nice job when they do the risk adjustment. And so if you pull those documents that are publicly available, you can look and see that for readmission or complications, whatever the thing is you're worried about, you can just look at the analyses that CMS has done on, millions and millions of patients. And that's what we did. And we're like, hey, look, that's where we got the categories. We got it from the data that CMS, the analyses CMS had done in support of their quality measurement development. All right, so here's some more information about the HSS at Home program. And as I mentioned, this is telephonic. The physical therapist would see the patient in the hospital before they were discharged, and then they would do a video visit with them, when they got home. And then they might do, additional visits. On average, ended up being about 5 video visits. And on the patient experience side, the HSS at Home was patients liked it very much. I mean, 4.9 out of 5. They also liked the home visits. That was 4.3 out of 5. So not a huge difference there. But the point is that the patients were very satisfied with this video visit. On the top right, we can see that the HSS at Home was less expensive. On average, there were fewer visits. Now, part of what's driving that large number of home health visits is the way that Medicare pays home health agencies, and they don't pay on a per visit. The rate, the amount of money they get paid depends on different groups. So it's not worth it at all for them to just do one visit because they don't get paid enough money. But if they do, and I don't remember the exact numbers, but say 2 to 5 visits, they get more money. If they do 5 to 10 visits, they get even more, money. But it's anything within that. So there's a weird regulatory or payment thing that goes on there that drives the cost for home health services. So we also looked at, post-discharge costs, and basically ended up saving about $4,000 a patient by using this HSS at Home program. On the bottom right, this is, I will say, it's a fairly small sample size, but we did see fewer readmissions, fewer ED visits, and fewer complications. And then on the left-hand side, we didn't necessarily think we'd see much of a difference between looking at patient-reported outcome measures, and we didn't. But the point is that patients who had the video visits did just as well, and they all improved. They had good outcomes, but the video visits the outcomes were just as good as with the in-person visit. So here's kind of where the rubber meets the road. Here's the money slide. So we were able to demonstrate higher quality for patients in the top left. So HSS already has very high quality, but even still, we were able to reduce the readmission rate and the complication rates, and the CAP score, which is patient satisfaction, patient experience, also improved. On the bottom left, we did see some improvement in the HUS and CUS Junior. Those are patient-reported outcome measures that for hip and knee replacement. Much more of an improvement in the CUS Junior than the HUS Junior. But again, the HUS Junior, this is the proportion of patients in achieving a minimally clinical important difference. It's already pretty high for hips, to start. But we did see I think a meaningful improvement for the knees. And then on the right, there's 2 metrics here on savings. So there were savings to Medicare And we anticipate during this period of time that the cumulative savings to Medicare was about $10 million just for the program. But then if you looked at this Medicare spending per beneficiary, all this stuff that we put into place for hip and knee replacement, was put into place generally at the hospital. And you can see that we went from 62nd percentile to 16th percentile. And we estimate that on an annual basis, when we're at 16th percentile, that's a $7.7 million savings to Medicare. So, good results for this. It was rewarding to do it, but it was a lot of work. This wasn't just like something easy to do. And so I think that some of the internal challenges to producing high value care generally are, for the CGI or any program, developing and or outsourcing the analytic capabilities. The analytics are so important. They are so, so important. You need, particularly if you're going to be engaging in a value-based program, you need to be able to model your likely profit or loss to determine if you're going to do the program or not. There need to be operational metrics to, drive your success. To establish owners of KPIs at all levels of leadership. So everything from the CEO down to, the nursing supervisor on a floor. You need to obtain consensus among your clinical staff for standard care pathways. The doctors and nurses are the ones who are doing all of this stuff. They have the power of the pen, and they know what they're doing. And the program is going to be a lot more successful if they're engaged in the program and helping to design and deliver it. Care needs to be coordinated, and there needs to be acceptance of new roles and care processes by clinical staff. So one example, I mentioned that in the US, social workers do a lot of the work in terms of triaging patients or determining, what the discharge is going to be. Are they going to go to a nursing home, et cetera? And we really kind of changed things up and put physical therapists in that role. We developed one specific role where we were tracking patients in nursing homes. And when someone goes to a nursing home after they've had an orthopedic procedure, the reason they're going there is for some level of rehabilitation. They're not, they're not going there because they have an infection or something else. And they don't need to be there very long. So we put a physical therapist in the role to really work with the nursing homes and to literally talk with them almost every day. She got information from them every day. And so when the patients went to the nursing home, we gave them an estimated time. Like, we think this patient doesn't need to be there any more than 5 days. And, she would check every day and say, is the patient on track to be discharged in 5 days? And if not, why? And we were perfectly happy to provide them with any of our pathways or help them out in any way that they needed. So that was internal. I think there were a lot of external challenges to producing high value care. And these comments are founded in the US healthcare delivery system, but I think that there are components that are relevant across the developed world. I think number one is overcoming a highly ingrained fee-for-service mindset. So we shouldn't ever be looking at the price absent the quality. We should be thinking about episode and population costs rather than unit costs. And there need to be payment models to reward the avoidance of unnecessary care. In the US, there is a massive fee-for-service infrastructure. Payer and provider systems are configured for fee-for-service. You do this procedure, you drop a bill, it goes through the adjudication process at the health plan pays. And introduction of value-based models often require system changes or manual workarounds, and the health plans are not well equipped to do that. All right, so it's just administratively very difficult for them to do that, particularly on a one-off. So, I sang the praises of HSS and does 1% of the hip and knee replacements in the US, but honestly, compared to other health systems, it's pretty small. And, insurance companies don't like to do one-offs because it's administratively expensive for them. You're going to be on gain sharing arrangements, ensuring payment that is sufficient to provide necessary high quality care. So, gain sharing is, and, the program I went through, CGR, is a gain share, right? So we've saved money and some of the money goes back to the providers. But at a point, you're going to squeeze out all of the waste, and then there's no gain to share. And the hospitals, have been looking at that share as part of their revenue. And if that's not there anymore, that's a problem. So you need to adjust the payment models. There should be flexibility in the way funds can be used in value-based programs. That was a big part of the success for the CGR program. Access to the data about populations that allows tracking of outcomes and utilization. So the fact that CMS made those data available to participants was rare. That does not happen in the US. Health plans have data. They generally don't share it with providers. And I think that there needs to be a way where these data can be made available to relevant parties. And there should also be waivers or a lot of regulations around financial incentives. In the CGR program, many of the physicians at HSS are not employed, including the surgeons, and it would be illegal. It would go against antitrust laws to pay them to perform a certain way. So there was a waiver that allowed us to share the gain that we got in that program with the physicians. That is a very, I think, country-specific sort of thing. But antitrust laws exist everywhere, and you got to make sure you're following the law. So I think just my last slide. I think when we think about changing from low to high value markets, I think this is what we want to accomplish. And on the left-hand side is a low value market. On the right-hand side is a high value market. And each one of the columns represents a hospital or a health system. And then on the far right on each side is everything combined. The kind of greenish bar is inappropriate care. The blue is new appropriate care. The red is complications or revisions. And the dark blue is appropriate care. And on the left-hand side, we can see there's a lot of inappropriate care, and that there's differences across the hospital. So hospital A doesn't have a whole lot of inappropriate care, but hospital D has a lot of inappropriate care. And I think what we want to do is set up the market in such a way that it incentivizes the high value providers so that they can remain in the market. So in this example, A remains in the market. They continue to have a low proportion of inappropriate care, but that light blue is bigger because they are able, since they're high value, they get more business, right? So there's a volume incentive. There should be a volume incentive for these hospitals. And it's a high quality place. And what we see is that, hospital D exits the market. That's a big deal, having a hospital exit a market on a lot of levels. And it might be that in certain geographies, a low value hospital can't exit the market. It's the only hospital, for miles and miles. So you need to think about how we can, draw that hospital into a high value care delivery system. Anyways, that's it. I'd be happy to take any of your questions, and I will stop sharing my screen.
Thank you very much, Catherine. As always, it always blows our mind away about the evidence that you're bringing. And I think everyone that is at home is seeing the huge impact and huge reality that a system that really is needing this whole efficiency is bringing along the way. and the way that you can connect the outcomes and the costs. And until I'm waiting for questions from the others, I'm going to start me doing and asking for some questions, very direct. Do you think it's possible to do a model of value-based healthcare without a good cost analytical model?
No.
Oh, that's great. Okay. So that's a good direct question. Secondly, a good accountability system for you to work with all the things. So what you cannot measure, you cannot manage. So it's impossible, like you said, to not do it. What was your biggest barriers when you start implementing all these methodologies? You talk about some of them, but what was the biggest barriers that you found?
The biggest, I'm sorry,
Barriers, the obstacles.
Oh, the obstacles. I think that the biggest obstacle in a big health system is getting everyone on board. And so I think that, it's just communication, constant communication. And that communication has to be backed up with evidence. And what we have found that works at HSS is that you have to kind of start out with a plan. You need to socialize that with some people, with relevant key stakeholders in the organization, and then you need to implement. And you can call that implementation a pilot, because then people don't get upset about it. And maybe not everyone's involved in it, but then when that pilot, we have found that when you implement a pilot, particularly if you have good results, then all of a sudden everyone else wants to be in the pilot as well. And so I think that the messaging is really important. And so, one of the obstacles is getting everybody on board, the clinicians on board. And they, like I said, they're the ones that are delivering the care, so they have to be on board.
Okay, that's great. You talk at a certain point that everyone should have their KPIs from the bottom up to the top down. How do you feel now? Because people are used to talk about global indicators about measuring the performance of clinicians, but people are not used for them to evaluate the guys that are on management. What was your approach for them to be this transparency approach? Because you're talking about a new way of doing stakeholder management on reality, and value-based healthcare brings this reality need.
Yeah, so I think there's a couple of things you have to keep in mind when you're talking about the clinician and trying to drive efficiency. So we never ever want to tell a physician not to, or a clinician, not just a physician, any clinician, not to do something that may result in harm to the patient. And I think you have to be really careful about that. And there are exceptions to every rule. And so when we're looking at the efficiency metrics, I think it's more useful to look at it on a population basis, or even the basis of population within a clinician, right? Because it may be that some of their patients, should have gone to a nursing home, right? And that being said, we also did some work where we defined appropriateness criteria for nursing homes, and any patients who went to those nursing homes, we applied the criteria, afterwards to determine if they met the criteria or not. And then we would go back and talk to the clinician and the social workers and say, look, these patients really didn't meet the criteria. Why did they go to the nursing home? So I think that it's important that clinicians are involved, but I think that, when I'm seeing a patient, what matters is the patient that's sitting in front of me, and I have to be aware of kind of the population, and I should never deny a patient a service that I think he or she needs, even though it, might not look good in the metrics, but you just have to understand that that's one patient, and there are going to be some patients who require these
Yeah.
services.
That's great. It's starting to appear questions. Great. One is a compliment saying, congratulations on the excellent presentation, Catherine. It's very important to understand the US and hospital surgery ecosystems and how they are evolving in terms of value-based healthcare. And I have a very direct question from Maria João. Thank you for a great presentation. How many KPIs should each team monitor?
So, you know, the trend these days is like everyone wants fewer measures, and I'm not necessarily an advocate of fewer measures. I think you need to have the measures that matter, but honestly, you know, every team is probably going to have, I would say, 3 to 5 measures, right? But if you look at, but there's lots of different teams, so there, you know, in total there may be far more measures than that. Okay,
great. Now a question about pathways. When you're looking to the pathway that is happening, is this pathway a living organism where you're reframing the way that you're seeing, or is very static on the way that you just do it and try to firm until the end?
So the pathways there's a lot of branching logic in the pathways. And so I think that the goal is to standardize things as much as possible. I would say that for clinical scenarios where there's a lot of variation, we're not going to have a pathway. We're going to have some guidelines and recommendations. But, you know, for things that are pretty standard, you know, there will be a pathway, and there shouldn't be a lot of deviation from it.
Yeah, great. Raquel, when you want to jump in, please go on.
I do. Actually, I have a curiosity regarding the CGR program, Catherine, that you mentioned it. I thought it was very interesting. Was it mandatory for HSS to join to do it?
So it was not. So at that time, the program was voluntary. And so that's why it was so important for us to do very good analytics to determine, you know, why would we sign up for a voluntary program where we might lose money, right? So we determined that we thought it was more likely we would make money, and we did make a lot of money on that. I mean, this is public information. Our reconciliation payments were about $8 million a year. So it was, you know, that's after everything, you know, all expenses. So it was worth it for us. This new model that has just gone into effect, the team model, is rather than being a 90-day episode bundle, it's 30 days. And there are a number of orthopedic procedures. There is abdominal surgery, some ophthalmologic surgery, cardiac surgery. And in CMS selected markets across the US where it's mandatory. And so if you are in one of those markets and do any of those procedures, it is mandatory that you participate in this program. New York is one of the mandatory markets. So HSS will be participating in this team model.
Yeah, I have also a question. It's very important, like you said, to have an accountable system. It's important. It's impossible not to have a good accountable, or else it's difficult to take decisions. But there's a question here that says, in Portuguese NHS, we base the system in resources, you know, not in the patient. How can we invert the focus to be put it on the patient in the center of the system when we all already have few resources, like lack of doctors, for example?
Yeah, it's a problem. I don't disagree. I think that PROMs are important, patient-reported outcome measures. I think that does pretty squarely put it on the patient, or, you know, put the focus on the outcome. But collecting PROMs is very labor-intensive, right? So I think that within your system, you can implement a program where if a patient shows up, you can collect that PROM. You can put it in your EMR. There's lots of ways you can make that standard for patients who show up. But post-op, you know, particularly for a procedure where most patients do pretty well, they may not come back. And you're not, and then you may end up with some selection bias. So if only the patients who have a problem come back, and those are the only problems that you're collecting, then it's going to look like you're not doing so well. So I think that we need to think, you know, at the population level about sampling strategies. And I think that I think for a patient that's sitting in front of a healthcare provider, the problems are important and useful. But for this larger population who like may not show up, I think we need to think broadly about how we might collect those measures and make them available to all the relevant parties, including the providers and payers.
Yeah. That will lead me directly to a question, you know. How do you feel this evolution about the stakeholders, suppliers, providers, and payers? Are you feeling it should be really the relationship among these new stakeholders approach?
So I think that there are lots of relationships, right? And so I think that you know, suppliers typically have the relationship with the health system. You know, the patient has the relationship with the provider. There are certainly suppliers who have relationships with clinicians, particularly when you think about devices, right? So there are relationships there. And then the payer, you know, has a relationship with both the patient and with the beneficiary, I should say, and with the health system. And I think it's important that these entities share information, right? There should be a nice free flow of information, of course, safeguarding patient privacy along the way, but there are plenty of ways to do that. But I think that if we could share the information among those different parties, they could all be more efficient in their own way. You know, so the device manufacturers, they really should know whether devices are working or not, right? And so they should know that. And clinicians should know whether their patients are getting better or not, even if they don't come back for a visit. So there should be a way to understand that. And, you know, the cost, at least in the US, most of the information on the cost of care, particularly across an episode, that lives with the payers. And if the payers don't share that information with the clinicians or the health system, how in the world are they going to become more efficient if they, you know, if they don't know where they're starting, right? So I think that I think every piece of the system would be better off with a more transparent data sharing.
Yeah, I think it's a very, very good word for us to finish at the moment, you know. I don't have any further questions. As you know, we are very enthusiastic about our talks about this thing. I think the word transparency is always the biggest words that we can get. And of course, this relationship among stakeholders, a good accountable system. The example of share savings that you gave, I think it's very great for people to see when we put a payment model going on, everyone goes and pushes up. So it's a good methodology and everyone knows that they're going to have the benefits on that. And Catherine, I cannot say anything more, just to say thank you very much to bring all the expertise and to show to the Portuguese people and administrators that value-based healthcare is possible, and this can be happening with good savings for everyone. And I'll pass the word to Raquel. Thank you.
Thank you, Philippe.
It's on mute, Raquel. And of course, Catherine, will count on you to come more time to Portugal. I'm definitely will invite you to come much more time. Raquel, you are on mute.
Yes, thank you, Philippe. So thank you, Catherine. So to close today's webinar, I'd like to thank once again Catherine and Philippe for this excellent moment of learning and sharing. I think we end this webinar cycle on a high note for sure. Thank you for being with us. The fourth edition of Mais Valor em Saúde program will continue In May, we have planned an in-person training session in Porto and Lisboa with the support of our local health units. These sessions will be focused on developing ideas and preparing pitches for applications to Mais Valor em Saúde grants, with the application period expected to begin around May. So stay tuned to the program's website and APA's digital channels where we will share the upcoming steps. And thank you so much, all of you, for being with us today. And I hope to see you soon. So have a good afternoon. Bye-bye. Take care.
Thank you.
Bye, Catherine. Okay.